I promised Gordon Francis I'd show this picture of the horses down the road from my house. You know, Kentucky is a place where the horses are pretty and the women are fast. Okay, so IRIS. Contrary to what you think, there's no widely accepted definition of IRIS. You know, we all think we know what we're talking about, but there's really no definition that we would regard as a gold standard. Loosely speaking, it's a paradoxical deterioration in clinical status attributable to recovery of the immune system. And as mentioned by Dr. Gold, it was first recognized with HIV infection after the introduction of highly active antiretroviral therapy. So you administer the therapy, there's a reduction in the HIV load, there's an increase in CD4 and CD8 cells, and a recovery of the T cell specific immune response. 90% of HIV, there's a reduction in 90% of HIV viral load within 2 weeks of HART. And IRIS typically develops in the setting of HIV 2 to 3 months after the introduction of HART, with a wide range between 1 and 104 weeks. Now, we always think, we had always thought of IRIS as being something that develops with opportunistic infections, and lo and behold, that's not the case. It's not just opportunistic infections. It occurs with autoimmune diseases, it occurs with malignancies, and in fact, there are even reports of IRIS developing with HIV dementia and HIV neurologic disease. So you restore the immune system, and there's this paradoxical response. With respect to infections, you can divide it into two groups, at least in the HIV population. One group is an unmasking of the infection. The other is a paradoxical worsening. When we talk about IRIS with natalizumab-associated PML, we talk about a paradoxical worsening because we already know that the patient has PML, their immune system recovers, and they paradoxically worsen. Whereas with HIV, interestingly enough, there are people in whom there's no evidence that they have underlying PML or cryptococcus for that matter, or TB. You administer the highly active antiretroviral therapy, and lo and behold, the disease appears. And that's called an unmasking of the infection. There are a lot of infections that have been reported with IRIS and HIV. I've listed them here. In the interest of time, I won't go through them, but it's also been seen with malignancies like Kaposi sarcoma, with sarcoid, with Graves' disease, and I mentioned even with AIDS dementia. It appears in the HIV population there's a lot to learn. There are a lot of parallels between HIV and some of these drugs that we're using. There's an increased risk with the greater severity of the illness. And PML-IRIS has been detected in up to 23% of all HIV-associated PML. Interestingly enough, in the HIV population, there's no association between survival and the presence of IRIS. I'll show you a slide that says the contrary, but it was very soft data, as I'll show you in a second. So why do you develop IRIS? And this is not well understood. I mean, loosely speaking, we think of this being the consequence of reconstitution of immune cell numbers and function, but there are a lot of things that occur: redistribution of lymphocytes, defects in the regulatory function, changes in the Th1, Th2 profile. There may be genetic susceptibilities and changes in antigenic load, all contributing to the presence of IRIS, and may account for the clinical and pathological heterogeneity that we see. So this is a case of PML-IRIS and HIV. At the top is the individual at the time of diagnosis in July 2004. The follow-up MRI is when they exhibited their IRIS, and you can see that the MRI is much worse. And what do we see? Well, typically what's seen is a clinical worsening of the disease. And in addition, there are MRI abnormalities, an extension of the lesion on T2-weighted image and flare, contrast enhancement, which may be transient, and even brain edema. You've seen this slide. This was one of Professor Gold's patients, but this is a case of PML-IRIS with natalizumab, and he's shown it, so I won't show it again, only to say, though, that it parallels what we see in the HIV population. Now, the pathology of PML-IRIS is somewhat different than the pathology of PML. The pathology of PML is a triad, first described in that paper in 1958 that I showed this morning. There's demyelination, as you see on the top, what it looks like grossly. Histopathologically, there's this loss of myelin that one sees subcortically as well as elsewhere. There are bizarre astrocytes in a large oligodendroglial nuclei that are chock full of virus. But one of the features that we don't often see in a routine case of PML is intense inflammation. That wasn't described when this entity was first written about. And that is characteristic of IRIS. Now, the question is, what is it? What are the cells that get in there? And I will tell you that the literature is a little confusing on this. There are some that contend that it is CD4 cells predominantly, and others that contend that it is CD8 cells. And I've listed two papers, one showing one and one the other, but they both show an intense perivenular or perivascular inflammation. What are the therapeutic interventions? Well, the common therapeutic intervention is high-dose corticosteroids, and this can result in a dramatic clinical improvement. There have been no increased report of adverse events with the use of steroids. And from the TAN article, which is an article written by Avi Nath and one of his colleagues at Hopkins when Avi was there, they felt that there was a trend towards improvement with the administration of steroids. It did not meet statistical significance, and this was in the HIV population. And in the accompanying editorial, I made that point. They felt that early steroid administration, high doses, and prolonged administration were important. I don't know if we know the answer to that. In a paper by Dave Clifford published in Lancet Neurology looking at the first 28 cases of confirmed natalizumab-associated PML, they contended that IRIS occurred in almost all the cases, was characterized by a subacute progression and exacerbation of earlier symptoms and enlarging MRI lesions or contrast enhancement. And it occurred even in the absence of PLEX, as you've heard a little earlier, and you'll see some of the same slides. The mortality from this series was 28%, 8 of 28 patients. And there's another very important piece of information that was alluded to in Professor Gold's talk as well, and that is just because you have IRIS doesn't mean the virus goes away. And this was demonstrated in Dr. Major's laboratory, individuals that have had IRIS with PML still surviving, looking at their spinal fluid, and finding the virus months after in some of these patients, which is contrary to what many of us had thought. This slide as well you've seen. I want to thank colleagues at Biogen for sharing this. And what it shows you is that the frequency of IRIS is the same with or without PLEX or immunoadsorption. So just because you've administered that doesn't mean that you're going to see IRIS any more frequently. When it occurs may be a bit different. There are no controlled trials to date on the treatment of IRIS. There have been several papers that looked at suggested therapies. There's a paper that came out of Hopkins in which they suggested to administer 1 gram of intravenous methylprednisolone for 3 to 5 days, followed by an oral taper over the next 6 to 8 weeks. There was a group of German authorities that published a similar regimen. I actually was included in that group. I guess you couldn't tell from the surname that I was the outlier. And that was using 1 gram of IV methylprednisolone for 5 days, followed by an oral taper over 2 weeks. And in that paper, they suggested that if symptoms persisted or worsened, then retreat them with the same dose, or to give IV methylprednisolone 2 grams for 5 days with the subsequent taper. But as I said, there are no controlled trials to date. And I'll leave you with these thoughts by Sir William Osler. Medicine is a science of uncertainty and an art of probability. Thank you.